Can we start now?
Yes, sir.
Here we have a patient who is 55-year-old male who had ischemic heart disease in the recent past. Now came with acute onset of breathlessness with some low BP. I am getting pulse very feeble. Can you manage this case?
Yes, sir. So we should start off by connecting the patient to the monitor.
So we are connected to the monitor. The EMT is connected. We can have all these parameters.
Yes, sir. Now you said the patient is suffering from breathlessness, so we have to keep him in a proper position.
Okay, keep the patient in proper position. So we are kept slightly in proper position.
So now I've completed my 10-second examination, and I found out that the patient is conscious and is well oriented to time and place.
GCS is normal.
Yes,
He is able to talk, but he is having some difficulty in talking. He is having breathlessness.
So what is the condition of his airway?
Airway is stable. He is having some gurgling sounds, but his saturation is only 84% now.
So are there any secretions obstructing the
Mild
airway?
secretions are there.
Okay, so we'll have to perform suction. So before that, we'll have to clear the airway.
Clear the airway with your suction.
So first we'll have to perform the chin lift head tilt maneuver. So now the airway has been cleared. So the airway has been cleared. So now we have to perform suction in the left lateral position or the recovery position.
Okay, we'll put the patient on left lateral position and just, we have suctioned the patient. Okay.
Okay, so now may I know what the oxygen saturation
Oxygen
and the
saturation is
respiratory
still
rate is?
same. It is only 83%. It is not improving.
Okay, so that, is the patient currently on room air?
It's on room air.
Okay, so we need to start him on oxygen therapy. So we'll start with the Hudson's face mask, which will give 4 to 6 liters of oxygen.
So we give 6 liters of oxygen through the mask. We'll see what happens to the patient condition. We have to wait for some time. Okay, now it is improved. With your oxygen, it is improved. But still he is having tachypnea. His BP is very low, 90/50. His heart rate is 109 beats per minute.
Okay, so may I know what the auscultatory findings of the patient are?
I'll see. I am auscultating on the back.
Yes, sir.
He has got bilateral crepitation, post crepitation, especially on the back. Anteriorly, he has got V's.
Okay, so for the V's, we can start him on salbutamol nebulization.
Start on salbutamol nebulization.
Salbutamol nebulization was started.
It is started.
Okay, so may I know about the chest rise? Is it adequate?
It is adequate.
So what about the bilateral chest movements?
Movements are
they
equal
on both sides? Okay, so now may I know if there are any distended veins or any use of accessory muscles in respiration?
There is JVP is elevated, but accessory muscles are like tightly in action.
Okay, so may I know what the heart rate and the blood pressure is?
Blood pressure is still, it is 90/50. Heart rate is 109 beats per minute.
So the patient is clearly suffering from tachycardia and hypotension. So we need to secure the patient with 2 large bore IV cannulas.
Can you put 2 large bore 18 gauge
16
needles?
or 18 gauge.
So we'll put two 18 gauge needles here.
2 large bore IV cannula secure.
So we also need to start him on 2 to 5 micrograms per kg per minute of noradrenaline.
Can I start noradrenaline now?
Noradrenaline 2 microgram per
This
kg
will
per
help
liter.
improve the hypotension.
So we'll try that.
Noradrenaline given, sir.
Given, it started.
Yes, sir, started.
We'll wait for the response. So BP is now 100/50. It's above, systolic BP is above 100. Diastolic BP is still 50. He is having left ventricular failure according to last echo report.
Okay, sir. So now that the patient's BP is above 100, we can start him on dobutamine.
Dobutamine. Can you start dobutamine?
Yes, sir, dobutamine infusion was started.
Okay.
So now we need to. The heart rate is still high, so we can start him on beta blockers, sir. So we can start him on tab metoprolol.
You want to start tab metoprolol right now, or you want to wait for some more time?
Then we can begin with the management of the heart failure. So we have to address the pain that the patient is having. So we
Okay.
have to start with sublingual sorbitrate, 10
Can you
milligrams.
give sublingual sorbitrate?
Sublingual sorbitrate 10 mg sublingual give.
Given.
So now we need to. So you said that the patient has basal crepitations.
Yes.
So this is mostly because there'll be some kind of fluid accumulation in the lung.
Okay.
So we'll have to start the patient on diuretics in order to
Okay.
minimize this edema.
Okay.
So we need to give him IV furosemide 40 to 80 milligrams.
40 or 80?
40 milligrams.
You give 40 milligram IV Lasix now?
Yes sir. IV
And-
Lasix 40 milligrams given.
Given.
So, and we need to give IV Lasix, and we can start the patient on inotrope in order
Okay.
to make sure the heart beats properly. So
Okay.
here, since the patient is already tachycardic, we can't use dopamine.
Okay.
So we'll be using dobutamine.
Okay.
So the dosage will be 2.5 to 15 micrograms
So we
per
have
kg
started
per minute.
dobutamine already.
IV
Its
infusion.
BP is just above 100, maintaining without any problem.
So now we'll be starting the patient on ACE inhibitors and
Okay.
ARBs.
What tablet you want to
Yes, so
start?
for ACE inhibitors,
BP has increased to 112 by 60.
so for ACE inhibitors, we'll be starting on captopril, captopril. We can give 6.25 milligrams every 6th hour,
Okay.
or we can even use enalapril,
Okay.
2.5 milligrams twice daily. And for the ARB, the angiotensin receptor blocker, we can give losartan.
Both together you want to give, or only one drug you want to give?
So we can give ACE inhibitors
We
first.
start Ramipril,
Yes sir.
6.25 milligram.
6.25 mg.
You start now?
Yes, sir.
Okay, it's already given.
So and now we can start the patient on beta blockers.
Okay, which
So,
one you want to
So
start?
we can use metoprolol, 25 milligrams.
Tablet or IV?
So we can start tablet.
You give a tablet
Yes, sir.
metoprolol,
Tablet metoprolol 25 mg.
given.
So now the heart rate should be reduced.
Heart rate, it may not reduce immediately because beta blockers will take some time. We'll watch. Okay, slowly the heart rate is coming down. It's going to a dangerous state. Is it reducing fast?
So heart rate is stable.
Stable. Okay. So now what is happening? You have to watch the monitor. Something,
So the oxygen saturation levels
it has reduced.
has reduced significantly.
We are not getting the.
So the
we are
rest-
not getting the pulse.
So
We are not getting the pulse.
So this means that the patient is entering into the patient is having a cardiac arrest, cardiac
Okay.
failure again.
Okay.
So we'll have to perform CPR right now because by the monitor we can't see a pulse. We can't get a pulse or
Okay,
respiratory
okay,
rate.
okay. Start
Breathing is
CPR.
absent, sir. Breathing is
He is starting CPR.
5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 16, 17, 18, 19.
So then while we are starting CPR, we also have to administer epinephrine. We need to give 1 milligram and 1 milliliter, 1:1000 dilution every 3 to 5
So you
minutes.
give adrenaline along with CPR. So don't stop CPR. Continue CPR.
7, 8, 9, 10.
So she'll be giving adrenaline as a
17,
bolus dose.
20, 21, 22, 23, 24, 25, 26.
Okay, come this way.
30.
Give mask. After every 30 CPR cycles, you have to give 2 breaths now.
3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14.
Feel the pulse now.
16, 17, 18,
Continue CPR.
21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
Okay.
Okay,
So now we are getting the pulse. The pulse has come back. The rhythm has come back. Previously it was pulseless arrest.
So
Now pulse is there, rhythm has come back to normal, heart rate is 79, saturation is still slightly low. Put the mask. Okay, put the mask. Okay. Okay, now the patient improved. So now we have to, now we know that patient has improved, his circulation has come back to normal.
yes, sir. So now there's a return of spontaneous circulation.
Okay, now he is turned to spontaneous circulation. We have to take care after that,
Post-cardiac
post-cardiac arrest care we have to give. Okay, now you understood how to manage a cardiac failure case.
Yes, sir.
This patient has come here with acute onset of breathlessness. Okay, why this breathlessness was there? Because his left ventricle was in failure mode. Okay, now what we have done for this patient? What all things we have done? You have to analyze what all things. Immediately you have to
Prop up the patient.
propped up, you kept the patient in propped up position.
Supply
You have
oxygen.
started oxygen. That is very important. When the saturation is less than 94, you have to start oxygen. Okay, then what you did?
Then after that we stabilize the blood pressure and the heart rate.
Okay, you have put an IV line.
Yes,
Two IV lines are very, very important, because once the patient collapses, it will be very difficult to put an IV line.
Yes.
So immediately after detecting that there is a cardiac failure, there is a chance of shock, immediately you have to put two IV lines. Okay, one IV line may be for your emergency management, one IV line may be for your fluid management, all these things. So two are required. So two IV lines you have put. Then you have started.
The drug management.
What are the drugs you have given?
First we give sublingual sorbitrate, 10
No,
milligram.
first we should never give sublingual sorbitrate, because this patient is already in hypotensive state. We have started noradrenaline here. Okay,
Noradrenaline,
we
sir.
can give sublingual sorbitrate, that can relieve the pain, but sometimes patient can develop hypotension. So we try to avoid that. We have started noradrenaline. Previous guidelines say you start dopamine, then dobutamine. Now every type of hypotensive shock in emergency room, noradrenaline is the first line choice. Other conditions like septic shock and all, fluid is the first line choice. Here we know that patient is having
Fluid
cardiac failure, there is fluid is already in overload state, we cannot give fluid. So we have started noradrenaline as a first line drug. Then after noradrenaline, once the BP has improved to 100/50, we have started dobutamine. Okay, so you should understand the difference between dobutamine and noradrenaline. Noradrenaline only improves the BP and increases the internal circulation, whereas dobutamine, it improves the pumping. Here there are two important problems. One is hypotension was there, that was reducing the internal circulation. Second problem was the heart is not pumping, so we corrected that with dobutamine.
Yes, sir.
Then suppose the patient is having bradycardia, then second line of drug can be dopamine. Okay, dopamine should not be started as first line drug.
Yes, sir.
here. So we have started dobutamine. Then during the episode you have started, the problem was you have started AC inhibitors and beta blockers during the acute phase. That drugs should not be given during acute phase. That drug should be given only once the patient is stabilized in your ICU. You should have a normal BP, then only you have to introduce it with a very lower dose and build up the dose slowly. Okay, what we have done is we have started both the drugs together. So you have started AC inhibitors and you have started beta blockers all together when the patient is having hypotensive shock. That is not permittable. You can start all these drugs only once the patient is stabilized, okay, in your ICU. So that was the mistake you have done during the treatment. Then what happened? Patient develops hypotension and bradycardia. Then what we did? We have managed the case by CPR. What is a good quality CPR? So he has done the CPR. What is a good quality CPR?
So it needs to be around 110 to 120 compressions.
So we have to keep slightly above the physiological limits. Physiological limit is 100. If you press only in 100, you may not get good circulation. So you go above the physiological limit so that you may get a better circulation. So you have started CPR at 100 to 120 cycles. Compressions. Okay. Then
you should give adequate chest recoil. So you should let.
So that is very important. When you press it, heart will pump. Okay. When you recoil it, when you take back the hand completely, what happens? Ventricle can dilate and it can accommodate lot of blood into that chamber. Okay. So that's why adequate recoiling is very, very important. Some technician, they press it and keep it like that, again press it. That reduces the volume which is coming out from the ventricle. So you have to press it properly, you have to give time to recoil. Okay, everything should happen in that 1 minute, 120 times you have to press also. Okay, so that requires some expertise in that type of compression. Okay, then.
So we should not give excessive ventilation.
Okay, so just 2 breaths are enough. If you continuously bag, what will happen? That itself will produce trauma, and that itself will produce reduced blood circulation to the heart chambers. The blood coming to the chambers will be reduced. So never try to give overinflate the lungs. Yes. Okay, just 2 breaths are enough. Suppose there is no other person, like third person is not there. What you do? You and your colleague is only there. What do you
exchange? One person has to first give
either you exchange for compression. One person has to compress. One person has to give breaths. Otherwise, hands-on CPR, like CPR alone. You no need to put the mask, because when you are pressing and releasing, actually air is coming inside. Okay. If you have a luxury of one more person, then you can ask them to bag the patient. Okay. So that was also given.
Then we also have to prevent interruptions.
Okay, so you should never interrupt. You should ask him to continue till that cycles are over. Then only you should check the pulse. So he has continued. We have never interrupted. Okay, and he completed, and we checked the pulse. It came back to normal. Now BP is good, pulse is good, saturation is good. So everything is good.
Yes,
now only we should start the medical treatment for cardiac failure.
Yes,
medical treatment means tablets. Okay, so previously in real case you have started AC inhibitors or ARBs or beta blockers during acute episode. That is not correct. Okay, we can only start that once the patient is stabilized. So what are the drugs you can give now?
So now we can give ACE inhibitors.
So AC inhibitor like enalapril, ramipril, all these things. Why it is started?
So they stabilize LV remodeling.
Okay, it prevents LV remodeling. It prevents the dilatation of ventricle. Okay, so one is that.
And they reduce the preload also.
Okay, one is that. One is that drug, AC inhibitor or ARB.
ARBs, and then we also have to start the patient on beta blockers.
So beta blockers, what is the action?
Beta blockers will help in increasing the ejection fraction. They reduce the heart rate.
So it only reduces the, it will not increase the ejection fraction like digoxin, what you learned, digoxin can increase the pump. But beta blockers never will increase the pumping. It only reduces the heart rate. When it reduces the heart rate, the oxygen demand comes down, the circulation improves. Then slowly, it ultimately it leads to improvement in the pumping. Okay, directly it will not help, but slowly it will also help to increase the pumping. Okay, so beta blockers, AC inhibitors. Third drug is one more drug in cardiac. Spironolactone. We are giving Lasix. Lasix removes water from the body. Excess water from the intravascular compartment will be removed. But to prevent remodeling, ventricular remodeling, additional drug you have to give, that is spironolactone. That also got action on, like diuretic action is there. That also help in removes the fluid. Okay. So 3 drugs are very important: AC inhibitors, ARBs, AC inhibitors or ARBs, or together. Okay, or sacubitril. So anything can be given with beta blocker, with AC inhibitors. Now he is also having a ischemic heart disease. What else you do? Ischemic heart disease is there. Any other drugs you want to start? So you are given sublingual sorbitrate.
Yes, sir.
Okay. So sorbitrate is nitrates. So nitrate should be given in all patients with ischemic heart disease, because it can dilate the coronaries, it can dilate your arteries, it can dilate your veins. Okay. So sorbitrate can be given. Then what else? So you have to prevent the problem in the coronary. How do you prevent it?
So we need to give
you have to give aspirin, clopidogrel, statin. So 4 more drugs you have to add with your existing regime. You have started AC inhibitors, you have started beta blockers, you have started spironolactone with furosemide. Then to prevent the ischemic heart disease or to control the ischemic heart disease, you have to start aspirin, clopidogrel, then statins, and if pain is there, sorbitrate should be given. Okay, so here you have given sublingual sorbitrate. Yes. Okay, what is the action of that? From sublingual route, it will absorb. It will, in any pain, any painful condition like chest pain, somebody is having ischemic heart disease, if you give sublingual sorbitrate, immediately it will affect. Okay, it will act on the heart, coronaries will be dilated. Okay, so that also can be given. Now, how do you proceed? Once the patient, you know that this patient is now having cardiac failure because of ischemic heart disease. Any other investigation you want to do?
So we can also look for an NT-proBNP, which is the...
pro-BNP, what will happen?
The pro-BNP will be elevated.
So in left ventricular failure, it will be elevated. You know, you can know that whether it is the failure, the problem is due to a cardiac cause or respiratory cause.
Respiratory
So
cause.
NT-proBNP can be done. Any other non-invasive test you want to do?
So we can go for an ECG to see the ischemic changes.
Okay, ECG can be taken.
TMT,
then
if the patient is
TMT now
completely-
at present patient may not be fit for TMT. You have to go for echo. Okay, echo. What all things you can find out?
We can understand the ejection fraction, how the left ventricle
So
is.
one is you can understand the ejection fraction. There are two types of cardiac failure. One is cardiac failure with normal ejection fraction, cardiac failure with reduced ejection fraction. Here it is reduced ejection fraction. Normal ejection fraction is diastolic dysfunction. Okay, this is systolic dysfunction. Okay, so echo can pick up the ejection fraction. Second thing, it can pick up the dilatation of ventricle. How much ventricle is dilated? Any valve regurgitation is there? Valve regurgitation or stenosis, which is common in cardiac failure?
Valve regurgitation.
Regurgitation is common. So that can even aggravate the problem. Okay, so that also should be done. Now you have to check whether any triggers are there in this patient. Why this patient has come suddenly to emergency room with acute onset of breathlessness? Is there any other problem existing in this patient?
So say if it's an infectious cause.
So you have to see whether any infections are there. Then
we can, if it's anemia. So
anemia is there.
CBC.
Okay, then
so thyroid function
test,
toxicosis,
okay.
Renal failure. So
renal failure.
Levels.
Okay, so these are the common things you have to rule out. So you have to check for the hemoglobin level whether anemia is there. You have to check for the thyroid function test whether any hyperthyroidism is there. Then you have to check for any creatinine, urea creatinine, whether any renal failure is
LFTs.
there. LFT has to be done because
heart.
cardiac failure can produce renal failure. Renal failure can aggravate cardiac failure. Same like that anemia. Anemia can aggravate cardiac failure. Thyrotoxicosis. Thyrotoxicosis can aggravate the cardiac failure. So all these things we have to rule out. Then only our the investigation will be completed. Yes. Any electrolytes you want to check in this patient?
Yes, sodium and potassium.
Okay. What happens to sodium normally in a cardiac failure?
So there will be a state of hyponatremia.
So it is a dilutional hyponatremia. Water is more, sodium will be relatively low. Yes. Whereas potassium, is it important in this patient? Potassium.
Yes, sir, it would be important. That's why we give spironolactones to prevent hyponatremia.
Because we are giving lot of Lasix that can remove potassium from your body. So we have to check that potassium, and if potassium is low, what will happen to your blood vessels and heart?
It will constrict.
Blood vessels will, the BP will increase. Okay. Hypokalemia, one of the feature of hypokalemia is increase in BP, and even cardiac pumping can also be reduced. Okay, but it is only a indirect effect, not a direct effect. Okay, so electrolyte does not have much role in cardiac failure, but you should know these are the problems can occur during your treatment.
Yes, sir.
Okay, anything else you want to add?
So it can also be drug-induced cardiac failure.
Which
from
drug can
negative
produce?
inotropes. So
what drug you want to add to your discussion?
So like verapamil or diltiazem can reduce. Also
any calcium channel blockers which has got which can reduce the pumping, like verapamil, diltiazem, can also create this problem. Like common cold medicines, what is that? Many brands are there, but they contains phenylephrine, pseudoephedrine, all these things. If this patient takes that medicine, what happens? Suppose a patient who is having cardiac failure takes a common cold medicine that contains pseudoephedrine, phenylephrine. What happens to the patient? What happens to the heart rate?
It increases.
It increases. Heart rate increases means what happened to the ejection? Pumping will reduce. Okay, the patient will go to cardiac failure. So try to avoid such drugs in this type of patients. Alcohol, same problem. Alcohol also can produce acute problem. Okay, so that type of drugs you have to reduce. And what type of exercise you advise for this patient after discharge? It is called as graded exercise. Suddenly you cannot do half an hour walking. It is not possible. So ask him to do one day 5 minutes, after 1 week 10 minutes, after 10 days, another 10 days, another 5 minutes. Like that, slowly his exercise capacity has to be increased. And once the patient is completely stabilized, then you can take the patient for angiogram, angioplasty, whatever you want. Okay, thank you.
you.